Fine. Today we are going to talk a topic which we usually don't see so commonly, that's the myocarditis. But one has to keep in mind when the viral infections are going on and somebody is presenting with dyspnea, one should just not only concentrate on lungs, always look for myocardium also, because in some of the patients you may find associated myocarditis which is producing LV dysfunction and dyspnea. So myocarditis is an acute inflammatory condition that can have an infectious, toxic or autoimmune etiology. Myocarditis can complicate many infections in which inflammation may be due directly to the infection of the myocardium or the effects of circulating toxins. Viral infections are the most common cause, such as Coxsackie and influenza A. Myocarditis may occur several weeks after the initial viral symptoms, and susceptibility is increased by steroid treatment, immunosuppression, radiation, and the previous myocardial damage and exercise. Some bacterial and protozoal infections may be complicated by myocarditis. For example, approximately 5% of patients with a Lyme disease, which is called by Borrelia burgdorferi, develop myopericarditis, which is often associated with AB blocks. Toxins such as alcohol and drugs such as cocaine, lithium, and doxorubicin may directly injure the myocardium. Other drugs, including penicillin, sulfonamides, and poisons such as lead and carbon monoxide, may cause a hypersensitivity reaction and associated myocarditis. Occasionally, autoimmune conditions such as collagen disorders, including SLE, rheumatoid arthritis, are associated with myocarditis. Now, the causes of myocarditis, as we discussed earlier, commonly the viral infections in the form of Coxsackie, adenovirus, influenza, HIV, and influenza A and B both. Bacterial, we have got Lyme disease and sometimes Mycoplasma pneumonia. Protozoal, we have got the Trypanosoma cruzi causing Chagas disease and Toxoplasma gonadi. Fungal, we have got the Aspergillus, and in parasitic, we have got the Schistosomiasis. In drugs and toxins, we have discussed alcohol, cocaine, lithium, clozapine, and anthracyclines. In autoimmune, we have got SLE, systemic sclerosis, rheumatoid arthritis, and sarcoidosis, and a hypersensitivity reaction to penicillin, sulfonamides, lead, and carbon monoxide. And this is the diagram how the virus affects the myocardium, leading to development of myocarditis and ultimately dilated cardiomyopathy. So viral enters the myocyte, viral replication, myocyte damage, which is due to the immune response mediated by lymphocytes, antibodies against pathogens, and ultimately leading to apoptosis of cardiomyocyte producing myocarditis, ultimately persistent or latent infection leading to chronic dilated cardiomyopathy. The clinical features, myocarditis may present in one of the four ways. Fulminant myocarditis follows a viral prodrome or influenza-like illness and results in severe heart failure and cardiac shock and carries a very high mortality. Acute myocarditis presents over a longer period with heart failure. It can lead to dilated cardiomyopathy. Chronic active myocarditis is rare and associated with chronic myocardial inflammation. Chronic persistent myocarditis is characterized by focal myocardial infiltrates, can cause chest pain and arrhythmia without necessarily causing ventricular dysfunction. Myocarditis is usually self-limiting in most patients with the immediate prognosis is good. Death may, however, occur due to ventricular arrhythmias as well as rapid progressively heart failure leading to cardiogenic shock, especially in patients of fulminant myocarditis. Myocarditis has been reported as a cause of sudden and unexpected death in young athletes. Some form of myocarditis may lead to chronic low-grade myocarditis, ultimately leading to dilated cardiomyopathy. In Chagas disease, the patient frequently recovers from acute infection but goes on to develop a chronic DCMP in 10 or 20 years. Investigations which are required in these patients are X-ray, ECG, echo. Cardiac MRI is the choice of investigation. Troponins, etiology, so viral markers, collagen markers to know the underlying etiology of myocarditis. So one has to remember the gold standard is cardiac MRI. And here you can see in cardiac MRI, myocarditis is very nicely depicted. Management is basically supportive. If your patient is in heart failure, treat heart failure. If your patient has got arrhythmias, treat arrhythmia. If there is any underlying etiology which is discernible, treat the etiological factor. Steroids and immunosuppressive therapy, especially in fulminant myocarditis, to prevent the left ventricle damage and cardiogenic shock, and avoid intense physical activity. So one has to remember that myocarditis is a diagnosis which is not readily discernible, so one has to keep always a higher risk of suspicion and then subsequently diagnose it and treat appropriately and try to prevent progression to the dilated cardiomyopathy. Thanks for your kind attention and thank you.